Hi, my name is Linda Johnson. I am here to present a case study done on the mycobacteria Haemophilus influenza for my class MLS 461. A 76-year-old male presented to the emergency room complaining of acute pain in the left shoulder, extreme fatigue, and high fever. He had no history of smoking, but he did have a history of hypotension and diabetes mellitus. Upon initial physical examination, he had a high fever of 103, blood pressure was 97/50, and he had respiration rate of 23 breaths per minute with noted crackles in the lower left lung. His WBC count was elevated at 28,600, and he did have a high CPR of 25. We did an initial body fluid workup, which we had an infusion, and we drained a yellow pleural fluid with results of pH of 7.4, total protein of 5.2, LD of 4,491, and glucose of 66. And he did have a predominant neutrophilia on his cytology smear. We continued on with microbiology workup on his respirated specimens. I put it on blood agar growth, McConkey, and chocolate and CO2 incubator. The blood agar had no growth, the McConkey had no growth, but the chocolate agar did have growth, and it was a clear, colorless, moist colony with a distinct bouncy odor. We also did a gram stain, which showed gram-negative bacilli, and a beta-lactamase, which was negative. I've included a flow graph to help ID the sample, noting that the growth on CO2 only, CO2 chocolate agar, only, the sensitivity showed susceptible to levofloxacin, piperacillin, ciprofloxacin, and gentamicin, and it was resistant to ampicillin. I also inoculated a quad plate. The quad plate contains 5% horse blood, X and V factor, X factor alone, V factor alone, and X and V factor. I included a chart showing the probabilities of Haemophilus samples that could grow on the quad plate. My organism grew on the 5% horse blood agar and on the X and V factor. It did not grow on X alone or V alone. Therefore, identifying Haemophilus influenza. A rapid antigen test for influenza A was also performed on this patient, and it was positive. So his primary diagnosis was influenza virus-related secondary bacteria infamy due to Haemophilus influenza. His treatment was they did a pleural infusion and administered pipramir and piperacillin and tazobactam. He was discharged from the hospital with a lower Y count of 7,600 and a lower CRP of 4.46. He was put on oral levofloxacin, though, for the following 2 weeks. A little bit of history about Haemophilus influenza. Haemophilus influenza is a small pleomorphic gram-negative coccobacilli. It may contain a polysaccharide capsule, and if the capsule is present, then the differential is into 6 different types based on the capsule's biochemistry, A through F. Strands not possessing the capsule are called non-encapsulated Haemophilus influenza or non-typable Haemophilus influenza. The non-typable Haemophilus influenza is a little more prominent now due to the hip vaccine that most folks get, and so we don't see that as often. Common signs of the Haemophilus influenza infections would be Hib meningitis, cellulitis, epiglottis, Hib pneumonia, Hib pericarditis, septic arthritis, occult bacteremia, and then in neonates we also see bacteremia, sepsis, meningitis, pneumonia, respiratory distress, and conjunctivitis. Also mucosa infections including otitis media and conjunctivitis. Common laboratory testing is gram stain of the body fluid or the infected site, bacterial cultures, and sometimes slide agglutination tests for the anti-sera or serotyping. The acute phase reactant tests that are usually done would be elevated sed rate and C-reactive protein. In conclusion, a non-smoking patient presented with pneumonia-like symptoms, elevated WBC count, elevated CRP, and pleural effusion. His diagnosis was achieved within 4 or 5 days due to the microbiology cultures and respiratory specimens, and then about after 2 weeks of antibiotic treatment, the patient's labs were within normal range and he was discharged with an additional antibiotic. I did have a few difficulties when trying to work up my Haemophilus patient. Due to HIPAA regulations, I had to present this presentation based on an online study. The case was chosen for the similarities in symptoms and results in diagnosis with a patient that I observed in my own facility. The plates and the organism pictured were inoculated by me. Thank you.